for the honor to speak with this elite audience. Great shout out to Uli, Deepak, and Brajesh and team. This is a great meeting. So I'm Sri Mummadi, and I'm a practicing pulmonary physician and one of the enterprise medical directors for clinical informatics at Cleveland Clinic. And the inspiration for this talk comes from the fact is what keeps what's my job as a clinical informaticist? Two things. How does a physician interact with the electronic health record? And how efficient is that interaction? And obviously the answer is it's really not efficient. And what can we do about that? And two, from the bean counters, what can we do to improve the quality of the care that is delivered via the electronic health record? And that comes down to the fact of number of tests ordered, number of high-cost medications ordered, are they really useful, and things like that. So Jugaad is basically a Hindi word. It's a South Asian term that's used to describe a frugal innovation that has to be fostered at the level of the consumer because of lack of resources. And you can see some of those examples there. And all the links, some housekeeping, all the links down here are working links. So I think the organizers can share the talk if they want to, and they're all working links. So these are all the list of abbreviations that I'm going to be using in the talk. So this is a question that I always get, how can I improve the quality of the care? And there are two options that you have. One is to display the price to the provider at the time of the workflows. I don't know how many of you actually use electronic health record in your daily workflows, but that's kind of been touted as one of the miracles of the modern day, where you can display price to the provider and let the provider make some rational decisions. And two, to the bane of my life and to many other physicians who use the electronic health record, intrusive alerts that just come into the workflow and disrupt your life, and maybe also associated with burnout. So these are the two questions, right? And the answer to the first question is, unfortunately, displaying price to the provider does not result in any influence on healthcare quality. And as much as it does not sound reasonable, the real answer in real lifetime randomized control studies, and all of them are randomized control studies, and only 4 studies have shown some decrease in orders, and the majority of the studies have actually shown no difference whatsoever. So physicians are irrational human beings. So that's the conclusion, right? Actually, all of the human beings are irrational. So, yep. So, and why does intrusive clinical decision support tools don't work? Well, they don't work because they're frequent alarms that threaten our autonomy, that basically disrupt our workflows and result in a sense of rebellion, being rebellious against the computer. That's what we do in the middle of the night, right? So I kind of like to think of this as a shove as opposed to a nudge. So this is where the nudge theory comes in. So for people who are very familiar with the nudge theory, you'll have to go through a minute of its introduction. But these are the objectives of my talk. What is the nudge theory, and what context it has to the electronic health record environment, and discuss the evidence surrounding its use and future implications of moving forward. This is just a small piece in the puzzle. The ultimate problem that we have to solve is the thoughtless and the mindless design of the electronic health record. The electronic health record was inspired from paper charts, and evolutionarily speaking, their DNA is to basically act as a revenue system. Therefore, no matter how much lipstick you put on that, it is a revenue building system, and therefore it is really not designed to help the physician or the patient. And that's the hard reality, and that's the shout out to the innovators and the entrepreneurs in the room. So nudge has been defined as an intentional restructuring of the choice architecture without the end user being aware of it, and also letting the end user preserve their autonomy. There is no restriction in the choices, and there are no tangible incentives attached to your choice making, meaning that this is in direct opposition to the rational school of economics, where it argues that people make rational decisions based on price and things like that. This is inspired from the behavioral school of economics, And anybody who's interested in the history, the 2017 Nobel Prize for Economics went to Richard Thaler for actually working a lot on the nudge. Extra electronic health record applications of nudge theory ranges from the men's urinals in Amsterdam International Airport to the UK government's the medicine nudge unit, which has worked a lot. So for example, painting a housefly in the men's urinal has resulted in a 85% reduction in the spillage and reduction in the cleaning costs. Likewise, putting fresh fruits and green leafy vegetables at the eye level in the groceries stores has resulted in an uptake of those choices. So all these links work. So EHR nudges are based on the intersection of three scientific disciplines. One is the physician-human-computer interaction. How do humans interact with computers, the user interfaces, the scrolling, how much stress it puts on the human eye as you scroll and scroll and scroll. Likewise, behavioral economics. Why don't physicians or even human beings make rational decisions? Always, right? We don't really we think that we make rational decisions, but we don't. And evidence-based medicine. What is an effective and an efficient medicine? Effective means a medicine or an intervention that works based on randomized controlled trial evidence. Efficient means what is the unit cost of that intervention? So both of them are not synonymous. Very important to make that distinction, effective and efficient. So what is an effective and what is an efficient intervention for any given disease? Right. So in that intersection comes the EHR nudges. So there's a lot of lack of clarity on defining what nudges are, but there are two nudges that come to my mind when I go into an electronic health record environment and I try to look, how can I improve this user interface for our colleagues? That's the default and the sorting nudge. The default nudge is basically introducing a pre-selected order or removing a pre-selected order from the order set. A sorting nudge is allowing the orders to be displayed in an order that we want instead of the default alphabetical order. Unfortunately, as much as simple as it sounds, as much jugaad as it sounds, it's frustrating to implement these changes in the current electronic health record environment. Unfortunately, so many vendors, or all the vendors, are not aware of this science and give us a lot of resistance when we ask for plug-and-play changes based on this. So again, a shout out to some of the innovators here in this room. So this is a good example. This is an workflow, and I cannot show any current electronic health record interfaces, so that's why I've created my own interfaces. So for example, we are trying to promote the generic uptake of prescriptions in the outpatient setting. So somebody types in vibramycin. Vibramycin is the prescription name for doxycycline. It costs $100. So what we've done is we've actually defaulted that to doxycycline. Now the physician has to take an extra step to say dispense as written. Only then the vibramycin is prescribed. If it's not done this extra step, a doxycycline is going to be prescribed, which is 99 cents. Again, a big difference there. So this is very similar to opt-in, opt-out on the organ donation, on the driver's licenses that has resulted in an uptake of organ donations across Europe. Likewise, this is a very busy slide. It was supposed to have animation, but this was in Keynote, so I had to convert it to a PDF. So this is just a collection of evidence out there, and you don't have to go into the details. The first evidence is basically someone looked at post-transfusion estimations for non-physicians and non-providers in the room. When somebody gets a blood product transfusion, we have to, after the transfusion, we have to look at the blood count and say, does this transfusion really improve the blood count or not? Like, for example, a red blood cell count or a platelet count. And guess what? Nobody actually orders them because physicians are very busy. They go by shortcuts and heuristics. And somebody did a natural experiment where there was no pre-selection, and then the post-transfusion platelet order was selected, and suddenly there was a big uptake. And this was just a pre-selected order, just put in the order set. No education, no formal training, nothing. And then that order was taken away, and suddenly there was a drop in post-transfusion platelets, orders being estimated. Likewise, somebody was ordering telemetry all the time for patients, irrespective of whether they qualified for it or not, because it was default selected in the admission order set. Physicians are heuristic animals. They go by shortcuts. They don't have time to sit and figure out what's going on in a busy environment. So somebody just removed that order, and they wanted physicians to put in the order if they thought that this patient benefited from telemetry. A natural experiment, boom, everything just fell down. This was wastage of resource that was clamped down. Likewise, many examples, and this was an example in the emergency room department where the default opioid quantity was 20, and that was selected in the post-discharge. They just removed that, and suddenly there was a drop in the number of opioid pills. So likewise, you can see introduction as well as removing, both work for default nudges. And again, all of those links work, so users are encouraged to go back. Likewise, just removing the telemetry automatic selection just resulted in that dramatic improvement. So for lack of, to keep the things moving on time, there was this very good randomized control trial that just looked at introducing an order called no default imaging needed. That was the order. And just pre-selecting it resulted in a dramatic drop of daily imaging reduction. And the population was palliative population undergoing radiotherapy. They just did not need daily imaging. There was no need to do any daily imaging. Just introducing that one single default resulted in a big drop. And this was a wedge randomized control trial, a very good design. So can't really argue with that results, you know. Likewise, the other sorting nudge. This is the order set for a typical COPD exacerbation. COPD stands for chronic obstructive pulmonary disease. In a large academic center, and this is how it looks like, right? What's happening here is that the computer is arranging all your orders based on alphabetical listing. That's why the first antibiotic is amoxicillin, and that's why the first steroid is methylprednisolone. There are no prizes for guessing what's the most common antibiotic used in this tertiary academic medical center for COPD exacerbation, and what was the most common steroid used for COPD exacerbation. A couple of years ago, there was a big COPD guidelines that were released that clearly stated that oral prednisone is as good as IV prednisolone for people with a functional gut, meaning that no nausea, no vomiting, they're good to get prednisone. And doxycycline was supposed to be the cheapest, in other words, efficient as well as effective antibiotic. So what we did was we went back and just changed it, and we had to fight tooth and nail with the electronic vendor to get the things to do this. So we introduced doxy as the first, and we introduced prednisone as the first. And again, no prizes for guessing what happened there. And then we took it a step ahead and said, why don't we combine the sort and the default nudge, and to avoid people who were getting prednisone for days together, right? So what we did was we defaulted the prednisone to 50 milligrams per day, and we said duration 7 days. Now, if you need more, take the effort and make it 10, right? If you need more, make it 14, right? But this was it. We just, no education, no fancy reaching out to doctors trying to convince them. This was just behind the scenes, right? And again, we achieved what we wanted with minimal efforts, and that's the reason why I call this intervention a Jugaad intervention. And this was another problem that was thrown at us. Adult ICU doctors were complaining that a lot of practitioners were using the blood culture ×1 for investigation of fever in the inpatient setting. Now, it appears that blood culture ×1 means that only 20 cc of blood is taken. And apparently, it's associated with false negative testing. In other words, this is an ineffective test, doesn't serve the purpose. It's an inefficient test, doesn't even waste of money, you know, trying to do this. So the big request for a clinical decision support to alert the user that blood culture ×1 is not needed, blah, blah, blah. I said, hey, look, I'm a physician, you're a physician. Is this what we're going to do out to our physicians, kind of alert them with intrusive alerts? So what we did was we just rearranged the order. And again, we didn't completely solve the problem, but there is an 80% reduction in the problem. Again, we had to fight tooth and nail with the vendors to get to do this. So we said, for lack of I don't want to sound this as a cliched manifesto, but I said, instead of coming up with this intrusive clinical decision support and all this, why don't we actually have a nudge manifesto or a checklist whenever somebody comes to us and says, we want this in the electronic health record? Can we just use basic design principles to solve our problem for our colleagues? And this is what I use as my own checklist in my daily informatics governance responsibilities. And I'm not going to read that list, but you can see avoiding alphabetical listing itself is a big deal. It's a big deal. And of course, listing oral medications before parenteral medications and things like that. And again, you can go through all this. This is a very interesting, while it appears a very jugaad choice, unfortunately, this is, I've been vetoed by the vendors for suggesting this. But that's something to keep in mind. There has been some research in human-computer interaction which shows that there are some fonts that result in more learning and recollection on the electronic screen as opposed to other fonts. So something to keep in mind for the innovators and the entrepreneurs. So how does this help us, the organization and the patient? I think it preserves our autonomy. I think it helps the patient achieve healthcare quality. I mean, we can assure that the care delivered is of high quality. For the organization, there is a reduction in the formal education and implementation costs for small interventions that aid to improve the healthcare quality. The disclaimer is that I don't think that this is a magic silver bullet. This is one of the many solutions that we need to move forward towards a revamped design of the electronic health record. The current state of the user interface is a thoughtless and a mindless a replication of the paper records. So this is one of the tools in the toolbox. So these are my take-home messages, but I'll stop here. Thank you.
How do you arrive at the best combination of efficiency and effectiveness? Because sometimes one is effective but not efficient, one is efficient but not effective.
So that's the third circle in my intersection, evidence-based medicine. I did not mention this, but without a subject matter expert on this project, these projects don't work. We have to have the subject matter expert in the room to tell us that doxycycline is effective and efficient.